Good afternoon, sir.
Good afternoon, Patul.
How are you, sir?
All well, all well. From this side, everything is well. How are you?
I'm good, sir. Thank you so much.
Okay. Okay.
So, are we good to start, sir?
Yes. Let me share the screen.
Yeah, sure.
Is it visible?
No, not yet.
No, sir, not yet.
Okay.
Now visible.
Abhi dekho, is it visible now? You are unmute. Unmute karo.
Yes, sir, now it is visible.
Okay. It is clear?
Yes, completely clear, sir. Just change your slides so that we can check with that as well.
Okay. ठीक है.
Yes, it's moving. Absolutely perfect.
ठीक एकदम बढ़िया.
So, are we good to start, sir?
Yes, it's time. We should be on.
Okay, all right. Good afternoon, everyone. This is Batul from IGCP, and I would like to welcome all the viewers at our platform who have joined this particular session for the better exchange of knowledge that is going to be shared by our keynote speaker, doctor, for today's session. And he's none other than a very renowned pediatric Professor Dr. Sunil Kumar Agarwala, sir. Sir is MD, Professor at the Department of Pediatrics at Sardar Vallabhbhai Patel Postgraduate Institute of Pediatrics. With the help of sir, we'll be taking a close look on today's topic, which is pediatric asthma management. Let us know more about the topic before moving on to today's session. Asthma, a common lung condition that affects millions of people worldwide, is characterized by the narrowing of the airways in the lung. In the pediatric population, the optimal treatment depends on several factors, including the age of the child, severity, and frequency of asthma attacks. We'll be knowing more about the topic with the help of sir, who will be giving us a better picture of the topic. So now, without any further delay, I would like to welcome sir at our platform and would like to hand over the session to him for his precious talk to begin. Sir, over to you.
Okay. Good afternoon. Thank you, Batul, for your kind introduction. And good afternoon, all doctors, those who have logged in spite of your busy schedule. As we all know, we are moving from old era towards a new era. And this new era, we are getting a lot of non-communicable diseases. For an example, asthma, hypertension, diabetes, obesity. These are the things which we are seeing every day-to-day practice, not only in adults, but also in children. So let's think about the asthma management in children. So if I say you, the asthma per se, more than 30 crore people worldwide are affected by asthma. 30 crore. Asthma accounts for about 2.5 lakh annual death worldwide. So this asthma, we have a myth that asthma is a disease in adulthood. Not like that. It can affect children, and usually the seed which is being given in the childhood itself. Many asthma, that means I can say near about 50-60% asthma, they start from the early childhood. If they are having history of atopy, if they are having allergic rhinitis, or any of the parent is having asthma, they, from recurrent wheeze, they will come out to a febrile wheeze and later land up with asthma, bronchial asthma, or branded asthma. Many parents, they were horrified by listening the asthma diagnosis, because everybody knows asthma is not curable. But I'll say asthma is a modifiable and manageable disease, just like your hypertension, just like your diabetes. There is a cure. Exactly, the cure word is not 100%, but it is the thing, the quality of life, the betterment, everything will be better on a protocolized management. The magnitude of the problem, asthma is most common in childhood, occurs in approximately 7 to 10% of the pediatric population. Now, globally, if I say, it may be more in metros. For an example, if you see the wheeze and the asthma percentage may be more in Delhi, maybe more in Mumbai, Calcutta, and you can say Hyderabad and Chennai. But it may be less in my city, Cuttack, where I am sitting here. But if you go to the rural belt, the percentage of asthma may be lesser. 40 lakh children suffer asthma attack per year. So this is not a small number. I've already told 2.5 lakh annually they die, and this is the huge number I'm talking of in children. So if I say asthma is the third leading cause of hospitalization among children under the age of 15, and it is the first ranking chronic condition. That means there are a lot of chronic conditions. For an example, juvenile idiopathic arthritis, you can say they are coming with collagen vascular disease. And similarly, we can see the asthma, which are long list is there for the chronic disease. But if you say, ask me, what is the number one? It is none other than asthma. So each pediatrician, I mean, each doctor, you should have been well versed with the asthma management, at least the key guidelines and the pillars of management, which almost every 1 or 2 years, the GINA guidelines, the global initiative of asthma, they are changing the modality of management. We have to follow that. In India, there are estimated to be 2 crore asthmatics in 15% children aged 5 to 10 years, 11 years old having symptoms. That means near about the bulk is 2 crore children amongst, if I say 40 lakh children suffer asthma attack a year. That means they are having the total bulk of number is 2 crore, but out of them, you see the total out of that, the 15% are in the children age group, or they are in the childhood population 5 to 11 years. When does asthma begin? It is $1 million question. By 1 year, it is 26%. 1 to 5 years, it is 51.4, and more than 5 years, it is 22.3. 77% asthma usually begins in children less than 5 years. So what I say, already I told, the asthma begins in the childhood and continues in the adolescent and adult period. And that's the reason we must know that how will you smell that this particular child will be asthmatic in the long run. Always remember, the childhood is the age of wheat. That means every alternate month you get a viral wheat. That again, almost all children, this has to suffer, or they will suffer from viral pneumonia or viral wheat. And out of them, gradually, if the asthma predictive index, which I'll be talking you later, and if that is high, then definitely there will be afebrile asthma, or there will be no atopy asthma or atopy related asthma. That means afebrile which will be there. So if asthma predictive index is on higher side, then definitely the probability of asthma in the adolescent or adult is much more. So suspect asthma. So dear doctors, whenever there is a recurrent cough, that means every often the child comes with only cough, and predominantly in the night, that is a variant of nocturnal asthma. Recurrent wheeze, and more particularly afebrile wheeze, that is most important. Nocturnal cough, I have already told. Recurrent dyspnea. If suppose somebody is going and running for a while or walking for a while and the child is breathless, then this is definitely due to exercise-induced asthma. Tightness of chest intermittently, recurrent ARI, and that is viral triggered wheeze and exercise-induced cough or wheeze. These are all variant of different presentation of the asthma in children. So dear doctors, all asthmatic do not wheeze, and all that wheeze is not asthma. I'll tell you, sometimes foreign body in the airway, sometimes the LVF, left ventricular failure, they also come as wheeze. Sometimes pulmonary edema, severe dyspnea, they also come as wheeze. So all that wheeze is not asthma, and all asthmatic, they may not wheeze. Some of the asthmatic, they may come with chronic cough. Some of the asthmatic, they will come with nocturnal cough. Some of the asthmatic, they will come with prolonged cough, or you can say persistent intermittent cough for more than months, and it is not being treated by any antibiotic or any antiviral. So that means this is known as asthma predictive index API. The asthma predictive index was developed by using data from children in the Tuscan Children's Respiratory Study Bath cohort. It was based on factors that were found during the first 3 years of life to predict continued wheezing at school age. So what has happened? More than 3 episodes of wheezing per year during the first 3 years of life. More than 3 episodes of wheeze per year in first 3 years of life. That means, and 1 major or 2 minor. So just like your Jones criteria, 1 major or 2 minor. So that means 1 major or 2 minor criteria. And if it is loose asthma predictive index, fewer than 3 episodes of wheeze per year, and 1 major or 2 minor. So what are the major criteria? Asthma in the parent, documented by the physician, eczema in the child. If these two things are there, they're definitely one measure. For an example, if I get a more than 3 wheats per year in the first 3 years, then what will happen if the mother or father is asthmatic? That means one measure or two minor. If they are not there, the child is not atopic dermatitis, then I'll go with allergic rhinitis in a child, because many allergic march will start from the atopic dermatitis, then go to allergic rhinitis, and end up with bronchial asthma. And either way, if I get a asthmatic child, there may be co-addition of allergic rhinitis. So you have to deal with allergic rhinitis management by inhaled nasal steroid and asthma management by inhaled corticosteroid. Wheezing apart from cold reported by the parent and peripheral eosinophilia greater than or equal to 4. This is known as minor criteria. So dear doctors, if asthma predictive index, it is the only one line we have to remember, that more than 3 wheats per year. That is one in the first 3 years of life. Either the parents are having asthmatic or there is eczema. That is a good, that we have to suspect that this particular child may in the long run will be a branded asthmatic. So what is asthma then? It is characterized by a reversible disease. That means there will be bronchospasm and it will be relieved by the bronchodilator. That's all. Airways showing chronic inflammation. This is a chronic inflammatory condition. Hyper-responsiveness to many agents, maybe in vivo, maybe in vitro, or they are maybe external and internal allergens. Reversible condition. It is a reversible condition. Once you treat with particular way, either bronchodilator or inhaled corticosteroid, it will bring back to the normal condition. Normal and asthma airways. What will happen? Normal airway, you see the architecture, the transverse section sage, muscles around, there are alveolar muscles. Air goes in and out through here, and the lumen is very much widened, and this is the normal cross section of airway. Now going to the asthmatic airway, the lumen is very much narrowed, and there is mucosal edema, there is bronchoconstriction. So that is the reason muscles squeezing around the airway, swelling and inflammation is there, smaller airways and mucus inside the airways. All together, that will lead to minimize the internal diameter of the airway. And this is known as, this is known as the reduction in internal diameter, and particularly this is very important to understand the what is normal and what is in asthma. And always remember, this asthma is a reversible condition by the proper management. Rule out alternate diagnosis. Always remember what is not asthma, or asthma is unlikely. Persistent wet cough. If there is a cough production, that is unlikely to be asthma. Persistent localized or monophagic wheeze. If you get some amount of disparity in the breath sound in the auscultation, that cannot be asthma. Focal or persistent radiological changes. If you see right upper lobe patch or paracardiac patch, then that is not asthma. Feeding difficulty, choking or regurgitation. It may be GR in children, very common. That is responsible for recurrent pneumonia. No response to asthma medication. You have given a ICS, but still then after 2 months, there is no improvement. So it may not be asthma. Persistent presence of stridor, that's age, laryngeal or tracheal pathology. Clubbing is there. Then it could be, you can say cystic fibrosis or alpha-1 antitrypsin deficiency. Failure to thrive. If the child is not gaining well, then definitely it may not be asthma. Neonatal or very early onset of symptom of which it may not be asthma. No association of symptoms with typical triggers. For an example, if there is a smoke, if there is pollen or any known allergen, whatever is there, for an example, smoke. So these, if they do not induce asthma, particularly, it may not be a case of asthma. So the meaning says that it is very a febrile condition. It is, you can say, a trigger mediated mast cell degranulation mechanism. So where there is more amount of histamine and leukotrienes, and they will be responsible for the muscular spasm, narrowing the internal lumen, mucus secretion, and altogether narrowing the airway lumen. And if you give bronchodilators suddenly or rescue therapy, there will be opening of that. So asthma, iceberg, breathlessness are the tip. Where you get dyspnea, that is at the tips of the iceberg. Otherwise, recurrent cough can be asthma, recurrent wheeze can be asthma, nocturnal cough can be a manifestation of asthma, tightness of chest can be asthma. Remember that all asthma does not wheeze. That means don't wait for the whois to occur to stamp it is asthma. It's not like that. Guidelines for diagnosis. Diagnosis is mainly clinical. This is a entity below 6 years. We don't have pulmonary function test. We cannot, because the children, they will not cooperate. So that's the reason below 6 years, you have episodic wheeze. You have more than 3 per year in the first 3 years. You are having asthma predictive index. I have already told history of asthma in the parent, or eczema in the child, atopic dermatitis in the child, or you are getting some minor features. For an example, eosinophilia 4 or more than 4. So these type of things, if at all it is there, you can see that it could be asthma. Episodic symptoms of airflow obstruction, more than 3 episodes are present. Airway obstruction is reversible once you treat with bronchodilator therapy, either by inhalational devices, by nebulizer, or by DP, or by MDI with spacer. Alternate diagnoses are excluded. Then only we can stamp it as asthma. Asthma phenotypes in childhood. This is transient wheeze. Many of the wheeze, 2/3, 70 to 75% wheeze in the childhood, early childhood, they outgrow from asthma. They do not terminate or land up in asthma. That means if I say atopic asthma, usually because history of atopy march will be there. Started with atopic dermatitis, maybe allergic rhinitis, and land up with atopic asthma. This is the typical graph. And sometimes if it is non-atopic asthma, then at certain point of time in the childhood, there will be cases or there will be episode of wheeze. And as the child grows, the incidences of episode of wheeze will be less and less, and maybe it may come out again towards the end part of the life. So asthma management, my topic was asthma management, pediatric asthma management. How we are going ahead to manage the asthma? What is the plan? Assess, intervene, and commitment. What is the assess? Assess the severity. What kind of severity it belongs to? That means you have to classify asthma, either intermittent asthma. If it is persistent, it can be mild, moderate, severe. Best achievable lung function can be done by LFT, but this lung function test is possible after 6 years by spirometry. Intervention drug has to be given, our trigger, aggravator, lifestyle changes. For an example, I'll tell you, once a child came to us who is having left to right on large VST and was on enalapril. And that particular child came to us with a persistent cough for more than 1 month. And once the this enalapril or AC inhibitor was stopped, then the very next day, the cough disappears. So we have to see that what long-term medication the child is getting, whether that may be a cause, that the cause of the cough. Not all prolonged cough are attributed to asthma. So what is the commitment? Right action plan for exaggeration. If at all the child is in school, how they are going to manage. Education of patient and family, very important, and review of the patient so that you can scale up or you can scale down or you can step up or step down for the management of asthma. So management of asthma concomitant having AR, allergic rhinitis and asthma, a strategy combining the treatment of both upper and lower airway disease in terms of efficacy and safety appears to be optimal. Montelukast, which is the commonly used leukotriene antagonist, receptor antagonist, has been found to improve nasal and bronchial symptoms with reduction of beta agonist use in subjects with comorbid seasonal allergic rhinitis and asthma. So inhaled therapy, if I say inhaled therapy is the cornerstone management of asthma, best form of control or therapy for asthma. So this inhaled, because we know that eye drops are there for the eye, ear drops are there for the ear, and there are skin ointments are there. They are known as topical therapy. And for asthma, you have to go for the topical therapy for the lungs. It is nothing but something molecule will be deposited into the lungs, will be instilled into the lungs by inhalation therapy. I'll talk you what are the inhalation devices, how the mechanism, and what are the different cadres, different types of inhalational devices are available for the childhood asthma management. Explain advantages, dispel the myths and fears. Sometimes the people will say that if you use this MDI or DPI, my child will be addicted, whole lifelong will be using this, and my future will be doomed. It is not like that. Select an appropriate device as per the age. You can't give DPI to a less than 4-year child. It's impossible. It's very practically difficult. Demonstrate how to use and ask them if the child is using properly or not, whether the parents are convinced or not. You tell what is the rescue therapy. When there is exacerbation, how you are going to manage. and what is the modality of management for the long-term management, that you have to explain. So inhaled therapy, inhalation devices are many like this. MDI with spacer, dear doctors, dear friends, there is no use of isolated MDI as of now, even in adults, even in older people. So MDI with spacer, spacer is a must. Another is MDI without spacer. For the scientific knowledge, I'll show why it is not mandatory or why it is not advocated. DPI use, dry powder inhalation nebulizer. So percentage of dogs deposited in the airway, MDI with spacer 40 to 60%. Without spacer is very less. That's the reason MDI without spacer is not advocated. DPI 5 to 10%, nebulizer 1 to 5%. Percent of drug deposited in the oropharynx, that is in spacer, if you use spacer, oropharynx deposition will be less, and MDI without spacer, oropharynx deposition will be more, and that's the reason the MDI spacer is equivalent to use of nebulizer as of now. DPI, the percentage of drug deposited into the oropharynx is high and 5 to 10%. So people say one of the best way for the management is MDI with spacer, but DPI is one of the alternative in older children more than 4 to 6 years. So inhaled therapy, inhaled steroid practice points, anti-inflammatory effect evident in 2 to 4 weeks. Local adverse event, oral thrust, dysphonia can be minimized by using spacer, mouth gargling and rinsing after use of moderate dose of steroid. But even mild dose of steroid, if suppose somebody practice the rinsing, the chances of dysphonia, oral thrust, all those things will be lessened. Usually required inhaled doses once you are dealing with budesonide 400 microgram per day in less than 12 years or equal to less than 800 microgram per day in more than 12 years, negligible systemic effect. So you may not go or expect there is HP axis suppression in required doses. So when you tell it is moderate, when it is per day therapy is 400 microgram per day, more than that. That means 100 microgram BD is a mild dose for budesonide, that you remember. Prolonged high dose, monitor growth, skin, eyes, bone, HP axis suppression, that you have to remember. But my dear friends, if you use the nominal use of, the mild dose of steroid, that is to the tune of 100 microgram BD, that is good enough to say that may not be rinsing is required, and that is not going to cause HP axis suppression, even if you use for more than 1 year. So estimated clinically comparable doses of ICS, we should remember only one, that is budesonide, less than 12 years, low dose, already I told 100 to 200, medium dose, double it, 200 to 400, then again you double it, then that will come 400 to 800. So that means the high dose is usually the normal pediatrician, a general pediatrician, a general doctor. We don't use medium. Again, the chances of use is very, very minimal, but we are happy with 100 to 200. And sometimes we are going with fluticasone, whose dose is again same, 100 to 200, and more than 12 years, it is again 100 to 250. So what I say that budesonide and the fluticasone dose remains constant 100 to 200. We must remember 100 to 200 microgram, because whatever available in the market, budesonide, this is 100 microgram per puff. So that much one puff BD is good enough. So classify severity. How you are going to classify? Mild, intermittent now, mild what is has been taken out. It is intermittent asthma, or mild persistent, moderate persistent, severe persistent. This is based on symptoms, limitation of activity, need for medication is there. But new classification, already I told that intermittent asthma, mild, moderate, severe asthma. So that means lowest level of treatment required to achieve patient's best level of asthma control is by classification. If it is a intermittent asthma, short-acting beta agonist as needed, just like Livolin, just like Asthalin, they are needed. But in case of mild persistent, you need low dose ICS. Already I told 100 microgram BD for at least 3 to 6 months or 1 year. Similar treatment or Leukotriene antagonist or sustained release theophylline. But we love to give Leukotriene antagonist, that is montelukast. Jafilukast is we are not using that, but we are happy with montelukast. The multiple brands are available now in Indian market with isolated montelukast or montelukast with levocetirizine, montelukast with fexofenatidine, and montelukast with bilastine. So these all are new add-on therapy or combination therapy is available. Low to moderate dose of ICS with LABA, long-acting beta-2 agonist, all other extra treatment is used for moderate. High dose of ICS and LABA plus minus oral steroid is an modality of management in severe asthma. So, dear friends, drug or device, which is more important? I'll tell the device is more important because drug is, we know that corticosteroid is the mainstay of management, but how you give, how the parents are convinced, how they are continuing the management, that is more important. You explain in the first visit and you check in the next visit whether they are continuing the proper device management or not. So orals are being converted to inhalers. Relievers are being followed by preventers. Plain steroid now are now converted to combinations. So drugs and devices, they are interdependent in each other. To have drug delivery into the lungs, you have a good device system, which is being fit to that age group, and that advice we have to give. Inhaler devices are likely to become more important than development of new drugs in the future. So devices for treatment of airway disease, the more than 65 different inhaled products of more than 20 ingredients are available. So I'll go one by one. That means factors affecting drug deposition. So device factors, particle size is important, ease of use is important. Whatever particle size, they should be lesser than 5 micron so that the drug deposition will be less in the oropharynx, in the mouth cavity, and the exact dosing will go directly into the lungs. Patient factors, technique, coordination, fast versus slow inhalation, breath holding, tidal breathing, airway geometry, all those things are important. We know pressurized MDI, which is the gold standard, and it is to be used never alone, static or non-static spacer, valved or non-valved spacer, with mask is a must below 3 years. So once you are using below 3 years, mask, spacer, and MDI is a must. Above 3 years, only spacer and MDI. DPI gaining popularity because of its small device, and it can be kept in pocket. It can be used at any point, even in the school, even in the working place, even in the classes, even in the jobs place, wherever you want to use, it can be used. Single dose and multi-dose types are available. Nebulizers for acute conditions, particularly those who come with acute severe wheeze, they are the main way of delivery of molecule is by nebulizer. There are multiple types of nebulizer are there: jet nebulizer, ultrasonic, battery operated, and you see the inhaler devices are particularly 3: MDI, DPI, and breath actuated inhaler. So MDI, the typical one actuator is there, and you see that this meter dose inhaler, this inhaler, and another is actuator. So that means actuator which contain inhaler into that, and if you press, one puff will be there, and it will go directly stroke into the oropharynx. So cold free and effect will be there. But if you use a spacer, that cold free and effect will be abolished. DPI, this is dry powder inhaler, either by Rotahaler or by Revolizer, or by, there are many other companies like Lupin, Lupihaler, and other companies, they are having different DPI methodologies there. Breath actuated inhaler, so that is autohaler kind of thing. If you take a breath, so that will take or release that amount of drug into the lungs. So coming to MDI first, also called spray inhaler. Sometimes people say it is a pump, or sometimes people in my state, they say oxygen, a cylinder. We are using cylinder one time BD, or one time twice a day. Releases a pre-meter dose on actuation. If you do this, that is known as actuation. And velocity of aerosol released is 70 miles per hour. So you see how fast it is being released from the inhaler into the mouth cavity and airway. So why pressurized MDIs? Widely used, available for all drugs, unobstructive, inexpensive, not dependent on patient's inspiratory effort. That means it is being designed in such a way that it will stroke into the airway, suitable for all ages, except you can say that the direct MDI is not nowadays advocated. It is always PMDI along with spacer is a must in each and every group, but mask will be added below 3 years. So this deposit aerosol released from the MDI that you see, 80% get deposited in the oropharynx and 10 to 20% deposited in the lung. So if you use, I mean, what I say, if you use this device alone, only 10% goes to the lung. But if you use spacer, the 20% it will go to the lungs. So that means actuators are the precision molded, providing the right orifice for dose accuracy. And you see the perfect inhaler. That means if I say almost perfect deposition in the lungs, small particle size, and no instruction needed, large patient satisfaction, and no hand-mouth coordination is needed, easy to take, but induces excellent patient compliance. That means if I say this 20% deposited in the lung, that means if you see 80% is swallowed and it goes to the systemic circulation, and again 80% swallowed, that being what I say, there is low chance or nil chance of HPA axis suppression by this methodology. So what I say, this is eliminated via urinary tract. So cold freon effect is the only disadvantages with MDI use, and a cold feeling in the throat as the propellant directly hits at the a very high speed. Now patient momentarily stops inhaling, so that will not be there with DPI use, or if at all you are using along with spacer. So use of spacer along with inhaler prevents the MDI spray from directly impacting on the throat, thus eliminating the cold freon effect. So technique of MDI. So what is the technique? Remove the cap, set the inhaler and exhale. Then you put it and take a slow deep inspiration as you press down on the canister and hold your breath for 5 to 10 seconds. Then breathe out. So this is the way you have to go for technique of PMDI. Now there are dose counters are available in multiple way. So once it is 0, that means shows no medicine left out and indicates that fewer doses are left. If it is red starts, and if it is green is going on, that means good number of doses are there. Advantages of spacer use, I have already told, overcomes coordination problems, and that means it reduces oropharyngeal deposition and decreases cold freon effect. So increases drug deposition into the lung. So remember, 10% drug is deposited only with MDI, but if you use a spacer, then definitely the delivery of the drugs to the lung will be double. So keeps the larger particles within. That spacer only allows the small particles lesser than 1 micron, they will be going in to the alveoli. So the first gamma scintigraphy study says that only DPI, that is 10%, and DPI with spacer, you have deposition to the tune of more than 20%. So pressurized MDI plus spacer is as effective as nebulized salbutamol in acute asthma. So that's why nebulization is the modality of choice in small kids, those who cannot inhale in a coordinated manner. But dear friends, you know that MDI with spacer is as good as your nebulization therapy. What is the ideal spacer? Static free. There should not be anything attached, or if you that a spray, then nothing is going to attach to the wall of the spacer. Volume ideal is 250 to 300 ml, shape similar to the aerosol plum, and valve type is the better. So transparent one, so that the patient will believe that something is going inside. And one of the company like Cipla, they are having 0 starts spacer like this, and they are having a kit, hop-up kit. That is from another one, MacLeod Max Spacer kit, and Lupin. This is Transpacer V, the VT. There is also, there are different companies have different modality, but 3 parts are there. One is MDI, another is spacer, which is visible, transparent, and 0 start means it is static free, nothing will attach to the periphery, and there is a mask. And with this, coming to the next modality of delivery of drug into the lungs, DPI, dry powder inhaler. Breathe actuated, no coordination required. That means you have to just like this. Easier to use, no propellants, lesser impaction as compared to PMDI alone. So these are the different variants of DPI devices are available. One is cyclohaler, rotahaler, another is your I can say revolizer. So one of the handy is revolizer. You open it and put the capsule. Always make the powder portion, the transparent portion will be bottom, and the color coded portion will be above. And you take a breath. The puncture capsule will deliver the lyophilized powder containing drugs into your lungs, in less than 1 micron, they will be going to the lungs. So that's the easy way that we can deliver drugs into that a long way. So that means this is one of the variety rotahellar, and people are happy to take rotahellar. Has transformed inhalation therapy. Child, they play, insert, rotate, and inhale. Economical, acceptable. Was a difficulties with MDI that is not there. Cold free effect will not be there. Every drug you need can be available in the rota cap formulation or trans cap formulation that can be given through this device. And this is one of the best device nowadays. Rotahellar, already I told, and it is now integral part of your lifestyle, because you know the burden of asthma in the community is very high. And another modality is revolizer. This is dry powder. The powder will be going into the lungs. So what are the benefits? Embodies the latest design technology, compact, robust, portable, and attractive. So appealing. It fits in perfectly as a personal accessory. And sometimes the asthmatics, they know that this is their life, and definitely whenever they have some distress or wheeze, they usually put one rescue therapy like Livolin, levosalbutamol, rotacap, and they take inhalation. Immediately they get relief out of that. So how to use? Open it, insert rotacap, and suck, inhale, and breathe easy. So this is the ways. So what are the pros and cons of this device? Positive, easier to use than MDI, easier to carry, breathe actuated, single or multi-dose types are available, compact, no propellants required, and lower initial cost. But what are the cons? What are the minus points? Inspiratory, flow dependent, older patient, severe COPD, acute attacks. This is not going to help. Not for all age. Usually it is recommended beyond 4 to 6 years of age. Some need loading, more expensive per day, and moisture sensitive. Dose lost if patient exhales into the device, and sometimes it contains lactose. Is there any other way of delivery? Already I told, one is DPI. I mean, another is your MDI with spacer. So introducing the autoinhaler. This is the new invention into the devices in management of asthma. Breathe actuated pressurized meter dose inhaler. What will happen? Autoinhaler improves lung deposition in poor coordinators. Those who are having persistent COPDs, chronic airway obstructive disease, autoinhaler, PMDI too early and PMDI too late. That means the percentage of drug delivery by autoinhaler is good in comparison with the other one. Selection of correct inhaler devices depending on age. Already I told 0 to 3 years, all the three has to be given: MDI, spacer, and mask. 3 to 6 years, MDI with spacer can be given. That means this is the way, or you can think of rotahellar in this age group, but ideally almost all respiratory people, they use rotahellar or DPI methodology above, I can say 4 to 6 years and above. In 6 years above, again, MDI plus spacer can be used, or DPI. Every 3 year, even 3 year child can use this, okay. But always remember, below 3 years mask, and we say around 3 to 6 years, it is MDI with spacer, and above that, the DPI use is more comfortable. So device, first choice, if less than 5 years, then MDI with spacer. Second choice is nebulizer, acute attack nebulizer. Older children and adults, DPI or MDI with spacer. Acute attacks, MDI plus spacer, already I told. And the second choice is DBI, and nebulizer is one of the methodology. High dose steroids, more than 500 microgram of fluticasone propionate or 800 microgram budesonide, PMDI plus spacer or DPI. Ease of use is DPI always, and second choice is MDI with spacer. So this I have already told. So the treatment of asthma, you see, our purpose, our main objective is that normal caliber of lumen of airway is like this. If it is inflamed, there will be narrow lumen. If it is conventional therapy, oral bronchodilator, it will partly treat it. But if you go for inhaled corticosteroid therapy for months together, years together, the partly treated dilated lumen or airway will be completely dilated, and it will modulate in such a way that the asthma may be curable. Yes. So that means many years of remission may be a possibility. So what is the conclusion? Clinician must be aware of inhalation devices. So if you are hesitating, that means it is very difficult to manage So definitely inhaler devices, the policy, the formula I have already told. You can use jolly well mask spacer MDI in less than 3 years, then MDI plus inhaler, spacer in 3 to 6 years, more than 6 years, again MDI plus spacer or DPI can be used. Train him, take few minutes from your busy schedule and check inhaler technique regularly whether excellent investment this that the child is taking properly or not. If suppose child is having a 3-step acute exacerbation, always the DPI method in bigger children has to be there with rotacap inside the bag. And at any point of time, their discomfort, they can take every 20 minutes, one puff, 2 to 3 puff in an hour as well. So important cleaning instructions. All the devices should be cleaned at least once a week. Already I told the mask, spacer, all those things. And it is recommended to use a new device if you are using for every day, the DPI, spacer, and mask every 6 months. This is the line. So the biggest driver of disease control is really the ability of person to use a particular inhaler device, because inhalation devices are there, the drug is there, the patient is there. But we are the doctors. We are the person or mediators which advise these inhalational devices in proper way containing the drug to deliver the adequate steroid therapy, inhaled corticosteroid or inhaled nasal steroid into the nose in cases of allergic rhinitis. So not to forget, patient counseling and education is very important. Drug control but not cure asthma. So symptom control over last 4 weeks decides the long-term management of that molecule. Intermittent asthma, no controller unless severe episodes are there. Inhaled steroids, mainstay of long-term management, use spacer plus MDI or DPI can be a modality of delivery of drugs. Step up or step down treatment based on response and compliance. So concluding remarks at last, I used to tell or I will be saying patients with asthma should be appropriately evaluated. History and physical examination for rhinitis. That means you have to know whether there is a comorbid condition known as allergic rhinitis. Inflammation is central to all of the allergic diseases. That means and anti-inflammatory treatment should be instituted only if there are ongoing symptoms. So that means sometimes this antihistaminic are also used if there is more amount of itching or associated itching due to atopic dermatitis or sneezing and too much of running nose is there. In addition to inhaled nasal steroid, in addition to inhaled corticosteroid, we have to use antihistaminic, but mind always antihistamines are given for a short period as like 1 week, 2 weeks, and thereafter solo this inhaled corticosteroid. If at all it is a mild one, then you can use the montelukast into them. So thank you very much, and I hope I have taken on time. That means somewhere about 40 minutes to complete my talk, and it is over to now Batul that you if any questions are there in the chat box, then you can send to me. So I am here to answer those questions. Thank you very much. Namaste.
Thank you so much, sir. Thank you for your such comprehensive talk and wonderful insight that you have shared upon such an important topic. Thank you so much for sharing it with us and for giving a clear picture about it. We have received few questions, and with all your due permission, I would like to put it across to you.
Yes, please.
The first question is, what is the role of valved holding chambers in the administration of medications for pediatric asthma?
Can you repeat it again?
Yeah, the question is, what is the role of valved holding chambers in the administration of medications for pediatric asthma?
Holding chambers?
Yeah, holding chambers in the administration of medications.
No, I didn't get really what our doctor is asking. So
I would, yeah, do you have any other thing to perceive from this and to answer about it? Or else we will ask the doctor to reframe his question and send it back to us.
That will be the best one, but I'll tell there are always remember in cases of management, we do make a room in the hospital. That means if a asthmatic child comes with acute exacerbation, we want to give which, and particularly we take to a chamber, and in that the devices are there like nebulizer and all. So we put that solution into that, and we give for the acute management not only once every 20 minutes interval, at least 5 to 6 doses of beta 2 agonist, and thereafter control we send to the bed and we manage accordingly, either short course of steroid, or if associated with fever and pneumonia, we have to give antibiotic, and many a times we just give inhalational devices with MDI and spacer thereafter for the long-term management. So the holding, this is one aspect, and another is holding chamber. That means this spacer is known as holding chamber. So this spacer is a must nowadays, along with your MDI. So MDI alone can deliver 10% of molecule to the lungs. So that's why if you use spacer, the deposition into the oropharynx will be lesser and more amount of drug will go directly into that. And that is the reason how you are going to hold this chamber into your mouth, and you shake it MDI at the other end and you press it. Once it is pressed, the whatever drug will be going through spacer, and somebody has to inhale like this. Then keep the breath for a while, and thereafter you can exhale. Over to Batul.
Thank you so much, sir. We'll move to the next question that we have received, and this question is, what is the preferred device for delivery of medications in children younger than 4 years with pediatric asthma?
Okay, already I have told, in less than 4 years, again we are getting a category of 0 to 3 years. I have already told the devices of choice is mask, then you go with spacer, and thereafter MDI. So mask is a mandate below 3 years. But after 3 years, going to the span of 6 years, many guidelines, they say that mask is not needed. Sometimes mask is needed, some majority mask is not needed. So the formula is that you can go for direct spacer along with MDI. So spacer plus MDI above 3 years, and below 3 years mask is a must. And above 6 years, there is another alternative, DPI. This I have already told in the slides, and this is my answer.
Thank you so much, sir, for answering this question. We'll move to the next question and the last question for today's session. And the question is, what are the safety concerns regarding the use of long-acting beta-2 agonist in the treatment of pediatric asthma?
So long-acting beta-2 agonist like salmeterol and formoterol, butyterol, no, not butyterol, salmeterol and formoterol, what will happen? These are known as long-acting beta-2 agonist, but usually they are not recommended in children 6 years. So that is the reason, if you ask, if you are using the mild persistent or moderate persistent asthma, it is always better to go with solo inhaled corticosteroid for a long period, maybe 3 to 12 months, maybe 6 months to 12 months. And it has to be given in the mild persistent asthma or mild asthma. That means you have to go with very low dose. I mean, 1 pop BD, budesonide MDI, 100 microgram BD, that will be good enough. But if you are using this LABA, I mean long-acting beta-2 agonist like salmeterol and all, so what is available as Seroflow or formoterol, whatever are available, they are recommended above 6 years. No studies there to use those molecules below 6 years.
Thank you so much, sir. Thank you for your comprehensive talk and for sharing all the answers with us. Thank you for your wonderful insight and for your valuable time that you have presented on our platform. Thank you so much for that, sir. With all your last comments, sir, we can conclude the session here for today. Until next time.
Yes. So before leaving, I must thank Batul and total team of those who have IJCP team made this event perfect. And I hope some insight I am able to give to my listeners, doctors, those who have logged into your this webinar. And it is the last comment is that asthma is on rising trend globally, and in metros and big cities in India, the same situation is also there, just like developed countries like Russia, just developed countries like US, UK, and Australia. And number two, it's not that asthmatic children, they will not have a quality life just like a normal child. Answer is big yes. But only thing, you have to smell asthma. I mean, you have to diagnose asthma. 100% it is diagnosed on clinical basis. Many a times PFT is not needed, and smaller children PFT is not possible. If you have a good asthmatic predictive index, then you can start inhaled corticosteroid therapy 3 to 6 months minimum. And as per the GINA guideline, you can step up and step down as per your control status is there. So always the devices has to be explained well to the parent so that the compliance of the drug, and many a times the difficult or acute exacerbation of asthma, or you can say status asthmaticus or acute severe asthma, it is due to the doctors itself, because we do not explain well. We do not tell that it is to be continued on daily basis. We do not tell that when to follow up. All those things, if it is planned way, then definitely we can give a quality life just like a normal child to the asthmatic children. So a long way to go, but still there are multiple, what I say, from different companies. The inventions are there. Now dose counters are there. You can know there are some buzzer will be there, which are in pipeline. They will be coming. That one sound will come so that the patient will feel that the drug has been delivered into the system. And many a times, always prevention is better than cure. So if you are giving ICS, then definitely acute exacerbation evidence, I mean, the frequency will be minimized to a great extent, and the child will go to remission for years together, and definitely we can have a quality life. Every parent will desire that their child will have a eventless, their child will have nothing in their life to go ahead, so that their school absenteeism, all those things will be minimized. So with this note, I will say that childhood asthma is now not uncommon, and it is 100% manageable by inhalational devices with the proper advising, counseling, and better compliance. Thank you very much, all my dear doctors. And at last, again, thanks Batul and the team. Thank you very much.
Thank you so much, sir, for such a wonderful note. What else can be a good way to end this session with such a wonderful note? Thank you so much for that, sir.
Thank you.
So with all your due permission, we are concluding the session here for today, sir. Until next time.
Thank you very much. Thank you.
Thank you, sir. Yeah. Have a good day.
Thank you.